Thank you very much. So nice to be here with you this evening. Can you raise your hand if this is the first time you've ever come to one of these sessions that Malcolm and I do? All right. Well, it's very nice to have you here, and welcome to the series. So you already heard about us, so we'll skip that slide. Just to catch you up, if you are new, we offer a series of workshops quarterly, and in March of this year, thank you, Shirley. In March of this year, we gave an overview of Alzheimer's disease and other types of dementia. So we focused on the diagnosis and how to differentiate these various types of dementia. In June, we talked about the treatment of Alzheimer's disease, the various medications. Today, we're going to talk about behavioral changes in Alzheimer's disease, as well as communication. And then in November, we're going to talk about risk reduction, as Josh mentioned. Now, if you missed the March or June sessions, you can go online and you can find those sessions online to catch up with some of that information. But we'll help you catch up if you have questions. So to help you catch up, for those of you who weren't here before, just wanted to show this slide and speak very briefly about the progression from normal aging to dementia. And we know that there's a long, what we call preclinical or silent phase to Alzheimer's disease. That's a period that can last 15, 20, or more years when there are actual biological changes going on, but there's no symptoms. So a good analogy would be heart disease, where you might have biological changes like high cholesterol, but you haven't had any symptoms yet, like a heart attack. So Alzheimer's disease is very similar in that extent. So the individual may notice that there's some changes in memory or feel like, oh, I'm not as clear as I used to be, or my memory's not as good. But if they went in to see someone like Malcolm, who's a neuropsychologist, and received a group of neuropsychological tests, they would score normally for their age. So that would be undetectable. Eventually, though, the changes that are occurring in the brain in this preclinical stage reach a threshold. There's so many that you kick over to where you're starting to show symptoms. And at that point, the individual may start to show symptoms that are noticeable to other people, okay? More noticeable to themselves. So at work, that might mean that they're missing appointments. One of the individuals I've worked with a lot, Steve, one of his first symptoms was that he couldn't remember the names of the employees he supervised, so he would address them by their title. So say administrative assistant or engineer, please do that, because he could no longer recall their names. So there are noticeable changes to others. But at this point, we don't consider the person to have dementia because that individual, excuse me for not putting that slide up, that individual is still able to function in everyday life. They're still able to meet all their everyday needs. They're taking care of themselves. Again, they may have some challenges at work. They may have to reduce their driving, but day to day they are able to function in the world. As the disease progresses and the person becomes progressively worse, and the impairments start to interfere with their ability to function and do their everyday activities, whether that be dressing or grooming or those basic needs, then that person has evolved into what we consider a dementia. And during this whole course, from MCI through dementia, there are a number of behavioral changes that occur as well as cognitive changes. Did you want to give your salesman example?
No, I think we're okay.
Okay. All right. So I wanted to just mention briefly a new framework for thinking about behavioral changes. As, again, Dr. Grill mentioned, I've been working in this field for 30 years, and when I started in the mid-1980s, we talked about behaviors as behavior problems. Then we started talking about behaviors as troublesome behaviors, and then we started talking about them as challenging behaviors. But today we've become a little bit more sophisticated in our understanding of the behavioral changes that occur. We understand that behaviors are a way of communicating. And so the way we refer today to behaviors is in a much more dignified way that recognizes that the individual is trying to communicate something. So we call them behavioral changes or behavioral expressions. So all of us express ourselves through our behaviors. All of you are expressing yourselves through your behaviors right now. I can tell who's paying attention, who's falling asleep. You're communicating through your behaviors, right? The thing is, I can ask you, if I don't understand what your behavior means, I can ask you and I can say, so, oh, you look like you're upset. What's that about? Well, when a person has Alzheimer's disease, the only way as the disease progresses that they can talk to us is often through their behaviors. We don't have that verbal language that they can explain to us, oh, I'm in pain, or I'm having some other difficulty. So we need to learn how to translate the language of behaviors. So we think about behaviors in a much more positive way these days, and we recognize that they're an expression of the person that we need to understand and respond to compassionately.
So the very term that Cordula mentioned a moment ago, mild cognitive impairment, that often leads to the assumption that there's only cognitive changes like changes in memory or in language and thinking abilities that are occurring during this very early stage. But in actuality, there's often a high frequency of behavioral problems or behavioral challenges or expressions also occurring. And in this slide, you can see that these occur anywhere from about 35 to 75% of individuals with MCI show these behavioral challenges. And the most common ones that are reported are depression, apathy, irritability, and anxiety. And what's interesting is that when you've looked at the risk of individuals who have MCI converting to dementia, because not all MCI patients will convert. There will be about 15 to 20% who actually will get better and go back to being normal. And there's another group who just sort of stay MCI for long, long periods of time. The ones that actually progress to dementia, they tend to have more behavioral problems as well as the cognitive deficits. So if we see an MCI individual who also has problems with notable anxiety and apathy or irritability, they are more likely to be the ones that within a few years will have converted to a dementia.
This was a very interesting survey that was done by the Alzheimer's Foundation of America of 750 caregivers. And it's really interesting to see that 2/3 of these caregivers right here before the diagnosis thought that the behavioral changes their loved one was showing was just a normal part of growing older. So in other words, they might have been adhering to stereotypes like, oh, he's just becoming a grumpy old man, and not realizing that irritability might be a symptom of something else, be it dementia or depression, but something significant was going on. And then when they looked at that 64%, 2/3 of those said, 2/3 of the 64% said that their belief that the behavior was just part of normal aging actually delayed the diagnosis. So we need to understand that when somebody's behavior is changing and is different from how they normally are, that this might indicate there's a condition that needs to be paid attention to. Now, there are many behavioral changes that occur during the course of Alzheimer's disease and other dementias. And this slide summarizes the various behaviors that you might see. I think one of the most important facts on this slide is you can see about the percentage of individuals with dementia who show those behaviors, and none of them say 100%, do they? Sometimes caregivers make assumptions or worry that, oh, my husband's going to become aggressive. Well, none of these behaviors are a fait accompli, so to speak. Everybody, how the disease affects them and how the disease affects their behavior is going to be varied from person to person. How it affects their behavior is also going to be affected by how we treat them. So there's a lot of factors involved in whether one individual has a behavior or not. But the reality is, I know Dr. Grill said about 70% of people with dementia will have these behaviors. Actually, some research has shown that it's as high as 97% will show one or more of these behavioral changes. So this is just very interesting. This study was done by Dr. Jeff Cummings in 1996, and he was following the course of behaviors across the progression of dementia. Well, when this study was done, the best we could do at that time was diagnose individuals with a dementia like Alzheimer's disease. They are already progressed into the moderate to severe stages of the disease. So by the time we diagnosed them, they were showing, thanks Malcolm, they were already showing wandering behavior. They were quite agitated or restless, perhaps pacing. But today, we're diagnosing the person very early. We're diagnosing them when they have mild cognitive impairment. When maybe the most prominent type of behavioral change you're seeing is some withdrawal, some depression, as Malcolm mentioned, apathy or a lack of motivation and initiative. So when we diagnose these individuals, and the types of behaviors at the time of diagnosis has definitely changed over the years. This slide just summarizes for you the progression of cognitive and behavioral changes across the course of the disease, noting that early on, the types of behavioral changes we see are going to be more, as Malcolm said, apathy and depression. Into the middle stages of the disease, we see more of that restlessness or agitation, anxiety, worrying a lot. We may see aggressiveness, delusions or false beliefs when somebody says things like, oh, this house isn't my home, you're not my spouse, that kind of thinking, and wandering. By the time the person progresses into the most severe stages of the disease, the behaviors start to ease and the person becomes much more passive. And eventually, as the slide indicates, becomes bedridden and moves towards death, typically from pneumonia or an infection that they succumb to.
This is just a chart showing the frequency and severity of behavioral problems at different stages of the illness. So we go from essentially normal adults who show very few behavioral problems like anxiety or depression. And as the person goes into MCI and into the dementia, and this is about a mild to moderate stage dementia, you can see the frequency and the severity, or how disruptive these behavioral challenges are to individuals, greatly increases. But what's also interesting is the caregiver burden, or the level of distress that it causes family members, also progressively increases.
Well, these changes don't really fall under quote, quote, behavioral changes, but as we think about how to respond to an individual and their changing needs, some of the other issues that come up have to do with the person who wants to keep driving when maybe that isn't safe, or who has weapons in the home and we need to figure out how to remove them, who is so depressed that they might become suicidal. someone who's living alone who's going through this disease. And we know that in the United States, there's about 800,000 people who live alone with this disease, making bad financial judgments, getting taken advantage of, like with a scam, being resistant to care, you know, not understanding that you are trying to help them, and then elder abuse and neglect. And a study was done here at UCI in the Division of Geriatric Medicine and Gerontology that showed that 1 out of 2 people with a dementia suffer some form of elder abuse or neglect, anything from psychological abuse all the way to physical abuse. So there are many negative consequences of these behavioral changes, and as the first bullet says, they're the primary reason for admission to a full-time care facility. Most caregivers say, oh, it's so much easier to deal with the memory loss, the forgetfulness. That's not a concern, but it's when their loved one starts to have behavioral changes that they're having difficulty managing. That's when placement usually happens. A person who's having some of these challenging behaviors also is going to have more difficulty functioning at home, doing their own daily activities, at greater risk for falling. Say that person wanders a lot, and they use more healthcare services, as you can see. Everything from going to the doctor more often to ending up in the emergency room because they're having a behavior that the caregiver is having difficulty responding to, and decreases quality of life for everybody involved.
Now we're going to talk a little bit about the limitations in the current medications that we have to treat behavioral challenges and problems. Cordula has already talked about how behavioral problems are probably one of the most distressful or upsetting aspects of this disease. They are primarily the cause of institutionalization, and they also are very disruptive to the individual. And you would think, with all of this importance placed on behavioral challenges and changes, that medicine and science would be greatly advanced in our understanding of why these behavioral changes occur, what are the changes in the brain. However, that's actually not the case. In fact, we know a lot less about why certain behavioral changes occur and how to treat them than we do about the cognitive changes. And last presentation, we spent the whole session talking about ways to enhance cognition, the memory and the thinking abilities. So ideally, the ideal situation when we think about how we would treat these behavioral problems is scientists and medicine would have a good understanding of what are the biochemical or changes going on in the brain of individuals who have these dementias. But unfortunately, we don't know that. There's very little known about some of these behavioral changes and what's happening in the brain. So what science and medicine has done is they've taken the medicines that were developed to treat other behavioral problems with different diseases, and they've used that within Alzheimer's disease and dementia. So they've taken the medicines that are used to treat schizophrenia or bipolar or mania or paranoia, where you often have things like agitation, hallucinations, delusions, and they've applied that to patients who have Alzheimer's disease. So this is often referred to as off-label use of a drug. So they're taking a drug that was devised and developed to treat another group of individuals and applying it off-label to treat patients with Alzheimer's disease. This is true for a lot of drugs in medicine. So for example, aspirin might be useful as a pain reliever, but it's also often recommended as a way of reducing the risk of stroke.
So first, just we want to mention or talk about briefly about a few classes of drugs. So benzodiazepines. These are medications that really we don't want any older adult taking, but we especially don't want older adults with cognitive impairment to take these, because these drugs have some serious side effects. They're used for anxiety, insomnia, agitation, and common benzodiazepines that you'll recognize the name of are Xanax, Valium, and Ativan. And you can see the reasons why we wouldn't want anybody who's cognitively impaired to take these is they make your cognition worse. They also increase the risk for falls. So these are a definite no-no when it comes to people with cognitive impairment, as well as really not good for any older adult. What about antidepressants? Well, we talked about that depression is frequent in Alzheimer's disease, and studies have really had mixed results about the benefits of antidepressants for people with Alzheimer's disease. And at least one recent study here, a couple of recent studies have shown that they aren't any more effective than a sugar pill. So we have to think about, when we give these drugs, about the potential benefit versus the side effect. And you can see with antidepressants, they can increase the risk of falls threefold in people with dementia. So I would say that I have seen people with dementia who benefit from antidepressants, but we really need to think about what these drugs do, a risk-benefit ratio to assess the value of these drugs for any given individual given their symptoms.
Well, some of the most potent of these drugs that actually are very difficult to use with dementia patients are these neuroleptic or antipsychotic drugs. And there's two main types. One is called typical antipsychotics, and these are drugs that actually had their first stages of development back in the 1950s and 60s. And then there's some of the common ones that you may have heard about are things like Haldol and Mellaril. These are drugs that generally physicians and psychiatrists would want to shy away with from using with dementia patients. There's a newer group of these antipsychotics which are called atypical antipsychotics, and many of these were developed in the 1990s and even more recently in the last couple of years. And these atypical antipsychotics, some of the most common ones are things like risperidol, Zyprexa, Seroquel. These are better tolerated. They produce less motor changes. So some of the earlier changes produced a lot of symptoms that looked like Parkinson's disease, with rigidity and stiffness and falling and tremor. The atypical antipsychotics also produce some unfortunate symptoms, and they have a number of side effects. So in general, you would want to shy away from both of these groups. These were the drugs that were initially developed for treating these other disorders like schizophrenia and bipolar. And they have a number of side effects, which we'll talk about. But why might not these drugs work with, say, Alzheimer's disease patients versus schizophrenia? And the reason for that is that the symptoms, although they may both be called psychotic symptoms of hallucinations, delusions, etc., these symptoms are often very different in one group versus another. So, for example, in schizophrenia, most schizophrenia occurs relatively young in adulthood. Alzheimer's obviously occurs for the most part in older adults. But in schizophrenia, they often have auditory hallucinations, so they're listening to God talking to them. In Alzheimer's disease and in other types of dementia like Lewy body, the most common hallucinations are visual hallucinations, where they're seeing like maybe their dead brother or their dead parent. They also, if they have delusions, the delusions are often very different in schizophrenia versus in Alzheimer's disease. The delusions in schizophrenia are very elaborate and they're very complex. So the person is having the delusion about someone, the CIA, shooting microwaves and trying to control their thought patterns. In Alzheimer's disease, the delusions are often related to the cognitive disorders. So someone stole my wallet, or someone is coming into my room at the nursing home and taking my things, rather than the fact that the individual has misplaced their wallet or misplaced their items. So the type of delusions are not these bizarre type that you get in the other types of disorders like schizophrenia and psychosis.
Yeah, one of the things I just realized that will be confusing to you is that these are actually reversed, because the drug response in people with Alzheimer's disease to these antipsychotics is poor. They don't work well. In schizophrenia, the drug response is good. Additionally, you'll see that people with Alzheimer's disease get better. In fact, studies have shown that if you just leave someone with Alzheimer's disease who has some psychotic features alone, that within 6 months they're likely to resolve all on their own. So behavioral changes come and go in Alzheimer's disease. They certainly don't come and go in schizophrenia. It's a persistent situation. And in Alzheimer's disease, because we know that behaviors come and go, they get better, we're going to use these drugs briefly. We're not going to use them for years and years and years on end. Whereas with people with schizophrenia, we want to start those drugs young, when the person is young, when the disease first emerges, and keep them on those drugs for a lifetime, because that's how they are most effective. And, you know, in schizophrenia, we're trying to help them develop some social skills. In Alzheimer's disease, we're really trying to maintain that person's quality of life through activities, adjusting the environment, teaching caregivers how to respond to the individual.
Well, as I mentioned, there's a number of side effects associated with these antipsychotic drugs. Despite the fact that they're given to millions of patients every year who have Alzheimer's disease, none of these drugs are approved by the FDA for use with elderly dementia patients. You see a lot of commercials on television, like common one is for Abilify. And if you actually listen closely, it will say this drug is not approved for elderly dementia patients. Yet it's given to a lot of dementia patients. The side effects that you can get with these drugs, there's what are called extrapyramidal motor symptoms. These are the Parkinson-like symptoms of rigidity and stiffness. In the worst case scenario, you can have something called tardive dyskinesia, which is where the person develops an involuntary shaking, like of their hands or their feet, or a lip smacking or a movement of their tongue. They don't have any control over this. It's usually seen in patients who are on antipsychotics for a lengthy period of time, but it can also be elicited with short duration treatments. Another problem that the FDA raised a warning about was that these antipsychotics increase the risk of death in dementia patients. And this is often due to things such as stroke and sudden heart attack. These antipsychotics also increase the risk of diabetes. They increase weight gain, so there's a number of negatives associated with this treatment. But the key thing is that none of these drugs, despite the fact that millions of prescriptions are written each year, none of them are FDA approved. And in fact, the FDA has a black box warning on these drugs for physicians to make them aware of the negative effects that they can have. Well, so let's say a physician ends up using these drugs. One of the interesting findings is that not only are they not really very effective in the majority of patients, but they also actually worsen cognition. There's been a number of studies that have looked at patients on these antipsychotic medications, and they find that they actually score lower than individuals who have some of these symptoms who are not being treated. In fact, we talked last time about the use of acetylcholinesterase inhibitor drugs like Aricept and Exelon and Razidine. They're designed to sort of boost up an individual's cognitive abilities. Well, these antipsychotics, they actually will do the inverse. They'll actually decrease cognitive abilities. So not only are they unsafe, but they actually worsen cognition. Another finding, which is often referred to as malignant neuroleptic syndrome, this can be a very deadly side effect of these medicines, and it's particularly common in patients who have Lewy body dementia. Lewy body dementia is what we've talked about in the past, where they have symptoms that look like Parkinson's, but very detailed visual hallucinations, and their mental abilities fluctuate up and down over the course of hours and days. In malignant neuroleptic syndrome, what happens is this can occur with as few as just one dosing, or it can also occur after multiple doses, but the individual becomes very stiff and rigid, almost stiff like a board. They also, as a result of that, they cannot swallow, they can't take in fluids or food. They're often develop fever, and in about almost half the cases, the fever is over 104 degrees. They can also develop arrhythmias in their heart. So they have a lot of physical changes, but they also develop more cognitive changes. They're very confused, very disoriented. So this shows the percentage of individuals that are affected by this malignant neuroleptic syndrome, and you can see it's higher in Lewy body, up to 81% of individuals, versus in Alzheimer's disease. So these neuroleptic or antipsychotic drugs have many negative side effects, and in fact, this particular syndrome can often lead to death. And we actually have had a number of cases of individuals in our clinic who we advise the family when they have Lewy body to always tell the physician, particularly if they're going to be hospitalized for any length of time, say due to agitation or hallucinations, to let the physician know that this is Lewy body and they should be very mindful of using any kind of antipsychotic. And we have had, unfortunately, at least one case of an individual who was entered into a psychiatric wing. He had Lewy body. The family told the admitting physician this was Lewy body, and the physician went ahead and prescribed high doses of Haldol, which is that early 1950s neuroleptic drug. The individual had this malignant neuroleptic syndrome, and within about 3 days had passed away. So you have to be very cautious about using these drugs, particularly with Lewy body patients. So are these drugs effective? Well, there's been a lot of studies that have looked at the efficacy of these drugs, and in a sense, they say that yes, these drugs can be a little better than sugar pill for some individuals, but you have to be very cautious in using them because of all of the potential side effects. And if you do use them, and if a physician does use them to, say, control agitation or aggression, which cannot be controlled through other means, then you should start very low on the dose and be very mindful of these side effects.
So, as Malcolm just said, if you use these drugs, you really have to think about how disruptive is this behavior to the person, and how disruptive or distressing is this behavior to the caregiver, and are the potential side effects really worth using the drugs? And that's that risk-benefit analysis that you have to do. But really, they should only be used in a targeted way for a specific behavior, and that you're monitoring if that behavior improves as a result of using the drug. You start at the lowest possible dose, and like I said, take a drug holiday. After 3-6 months, it's time to stop the drug and see if the behavior's still there, because behaviors will will go away spontaneously, resolve themselves spontaneously in dementia. So, since the drugs don't work that well, we need to develop some skills to help us respond to people with dementia compassionately who have these behaviors. And actually, the California Southland chapter of the Alzheimer's Association came up with this nice acronym that will help you in the future as you're trying to understand behaviors. It's called the IDEA approach, and I hope when you leave here and you are maybe caring for someone who has a behavior, that you'll remember, I've got to come up with an idea. And so what does that mean? Well, coming up with an idea refers to, the ID refers to identifying and describing the behavior. That's the first thing that we need to do. Second thing is educating ourselves about what the causes or triggers might be of the behavior. Is there something that we can change that will help reduce this behavior? What's the meaning? Remember I said behavior is a language, so what's the person trying to say? And then adapting or problem solving. And we're going to talk about each one of these aspects a little bit, but first of all, we want to ask what is a behavior, and let's put the onus on the caregiver right now, the behavior that you're having difficulty responding to. So is the problem really with the person who has the dementia, or is the problem with the carer who's not understanding how to care for that individual or respond to them? So we need to know things like where's the behavior happen, when does it happen, how often does it happen. It's kind of like what we need to know to figure it out is reporting it out or describing it like you would describe a scene in the movie. I work a lot with care communities, and staff will say to me, oh, so-and-so's really agitated. And I'll say, well, you really haven't told me anything. I don't know what to do. What does that mean? Words like agitation and anxiety, they're kind of code words. We need to decipher that code and understand exactly what's going on. So that's what we're going to talk about, how to do that. So we'll start with educating yourself. Now, assuming that you've described this behavior, you understand when and where and how often it's occurring, then you start to think about what might be going on here. So in terms of what might be going on, the things we definitely want to consider, is there anything medical going on that might be contributing to the person's behavior? Is the person telling you that they're in pain, or something else medical is going on? Is the behavior as a result of the cognitive changes that they're experiencing? Maybe there's something psychological going on, or maybe there's something in the environment that's triggering the behavior. So we'll just talk a little bit about each one of these.
So whenever you have a sudden, particularly a sudden change in behavior, one of the first thoughts that should come to your mind is this due to a medical or a health-related issue? So don't do what a lot of people do, is they just dismiss the symptom as being part of sort of the normal dementia process, and that this is just something that we have to accept. So if you see a sudden or marked change in behavior, first of all, think, is this a medical problem? Because most often this is due to either a worsening of a pre-existing condition. It could also be related to the use of a new medication or a change in their medication regimen. Or it could be something as what we might think is minimal as giving, say, a person with a cold over-the-counter drug, an antihistamine that may cause greater confusion or agitation. It could also be related to another problem, which is delirium, which we'll talk about in a little bit later. So the key thing is, if you see a sudden change in behavior, think about medical issues first. It's surprising that research has shown that there's often a lot of unrecognized medical conditions. So studies have been done that look at patients who are entered into, say, a nursing home or an assisted living facility or an acute care ward, And the physicians actually have missed, or they have not detected, a lot of underlying medical conditions. And the most common ones that are seen are things such as constipation, urinary tract infections, anemia, also things such as dehydration. Those are very common, and hypoglycemia. And what's interesting, all of these medical conditions, dehydration, problems with sugar in the blood, either too high or too low, constipation, all of these are associated with an increase in things such as behavioral problems like agitation, aggression, irritability, vocalization, shouting or screaming. So the presence of these undetected medical problems actually can worsen a lot of the behavioral changes.
Yeah, just think of yourself, you know, if you were to feel constipated, how uncomfortable that is, how that changes your own behavior. And then think about if you couldn't tell somebody or come to a way of yourself resolving it. So we can understand how these behaviors come up. And as Malcolm was said, you know, when an individual has a medical condition that's underlying their behavior, the studies show, yeah, they're more likely to refuse care or to be resistant. They're going to be impacted, their cognitive abilities are going to be impacted, and their ability just to function and do everyday activities. And guess what? They also were more likely to be given one of those psychotropic medications because nobody actually paid attention to whether this was a medical condition and whether by treating the medical condition they could resolve the behavior. So again, there was that kind of automatic assumption, this is just due to dementia, we'll give them a psychotropic medication, and so then you're on a downward spiral. Whoops. So we wanted to just show you a brief video about delirium. Delirium's a little bit of a difficult concept to understand. It's when you become confused, your mental status changes, and that can happen to any of us. That can happen to someone who's cognitively normal. So actually that happened to me once when Malcolm found me in the bedroom a few years ago, and I was hard to arouse and confused, and ended up anyway, the story ended up I had an ulcer, but the point being is it was a change in my mental status, and even people with dementia have their own normal. They have their own baseline, and they can experience a change in mental status called delirium on top of that, which makes them even more confused and changes their behavior. So hopefully this video will help you understand that concept.
There is a condition that is difficult to detect, but it can be a medical emergency. It's called delirium, and there are two basic kinds, quiet and excited. They may look a lot like dementia, but they can be particularly hard to identify. If you are a caregiver, you need to know the signs of quiet or excited delirium and what to do about them. The first one we'll cover is quiet delirium. Here are some signs you should look for. Your loved one may not be thinking clearly or have trouble paying attention, not be aware of what's going on in the immediate surroundings, may seem out of touch, avoids making eye contact, might not know who you are or where they are, and may occasionally see or hear things that are not really there but seem real. These symptoms are different from your loved one's usual behaviors. Other symptoms can include slurred speech, answering very slowly, talking about things that don't make sense, and looking or appearing very sad. Let's see how this works with Frank and Doreen.
What are you watching, dear?
Why don't we shut this off until after you've had lunch?
The train should be pulling in soon.
What train, Frank?
I gotta get on the train. We're gonna see all the fish.
Here, why don't you try taking a bite of your sandwich? Frank, wake up and eat.
A fish of water.
Frank, what do you say? Wake up! You need to take one of your pills. Here, take this.
Who are you? I wanted some tomatoes.
This isn't right. It's never been like this before.
This is quiet delirium. Your loved one suddenly just doesn't seem to respond to you in the usual way. It happens when a serious medical change occurs large enough to disrupt physical and mental functioning. As in this scenario, Frank is different because something has changed about his health. Doreen needs to contact their medical caregivers as soon as possible.
Yes, it's my husband, Frank. He's a patient there. He has dementia, but I've never seen him like this before. I don't know what to do. Please, can you help me?
Doreen did the right thing. The doctors and the rest of the medical team will work to determine what medical problem is causing Frank's behavior. In the meantime, she should stay calm and try to comfort him. Quiet delirium can appear unexpectedly. Now let's look at a more extreme and difficult aspect of delirium, and it can be dangerous. Notice the changes in Frank's behavior. The symptoms of excited delirium are more obvious than those of quiet delirium. They may include restlessness, attempts to get up and move around with no apparent purpose, aggressive or random behavior with various objects, and fearfulness. Like quiet delirium, however, they last longer than episodes of agitation and dementia. Other symptoms can include physical attacks on caregivers, such as punching and pinching, yelling, throwing objects, being disoriented, and not recognizing the caregiver. As with quiet delirium, your loved one will probably not be able to understand or explain why they are acting so differently. But you need to realize that the situation has changed radically. A person who is experiencing excited delirium needs professional medical care.
How you doing, honey? It's time for your pills. I brought you a glass of water.
Get out!
Oh, Frank!
Out of here!
Oh, no, that's all right, it's all right. Just stay down, Frank! Frank, you're hurting me! Frank, let go!
You must act quickly. Just as with quiet delirium, excited delirium is a medical emergency. That leaves it to you to take the only step possible.
Yes, I have a medical emergency here. My husband, Frank Taft, he's out of control. He needs to see a doctor right away. Well, he's throwing things. He grabbed my wrist. He's talking out of his head. I've never seen him like this before.
This is different than dementia. It comes on quickly, and the usual approaches don't work. Look for these symptoms: restlessness, attempts to get up, aggressive behavior, fearfulness, physical attacks on the caregiver, throwing objects, being disoriented, not recognizing the caregiver. There are warning signs that your loved one needs immediate and professional medical help. Remember, you did not cause it, and you cannot handle it by yourself.
So the main point there is Frank has dementia, right? But he's different than his normal. And sometimes when a person with dementia develops a delirium, again, it's kind of thought that, oh, it's just due to the dementia. But a sudden change where the person is different than their normal is something that needs to be paid attention to.
And also that these are often acute, they come on suddenly. So unlike in dementia, where a change in cognition might be a very slow, gradual process, these are often marked changes that occur very quickly, but they do need medical intervention. So some of the medications that can cause behavioral changes, these are listed here, and many of these have what are called anticholinergic effects. And anticholinergic effects include things like rapid heart rate, dry mouth, confusion, difficulty concentration, memory problems, and even in hallucinations. So I don't know if any of you have ever sort of taken too much of an over-the-counter cold medicine. So no one has. But sometimes, like, if you have taken too much of a cold medicine, you might notice that your heart rate increases. You might also notice that it's harder for you to concentrate or that you're having memory problems. So these things, if you already have a dementia, we certainly don't want these things to be added to that. It can make things a lot worse. And the interesting thing is that a lot of families that we see, the patient is on the standard medications like Aricept or Namenda, maybe they're taking an antidepressant. Person comes down with a cold. And so the family says, oh, well, the person's not sleeping well, let's give them some Benadryl. And then they say, oh, well, we've noticed that he's much more agitated, he's restless, he's much more confused, he's not recognizing. Is this just part of the dementia? And well, it's because he's probably taking too much of this cold medicine, and if he's also taking other drugs that have anticholinergic side effects, these can worsen things appreciably. So the more drugs you're taking that have anticholinergic side effects, the worse and worse the behavior. I just put this slide up. We had seen this slide before, in fact, at our last presentation. And the reason I'm putting this up is that this slide is very important in that it shows that the use of certain medications, particularly anticholinergic drugs, has been associated with an increased risk of developing dementia in healthy older adults. This was a study, it was published in January in the American Medical Association journal, Internal Medicine, of this year. And what they did is they studied a large group of healthy older adults, followed them for over 7 years, and they looked at their use of non-prescription over-the-counter drugs. Many of these are ones that you'll be familiar with. These were things like certain antidepressants, antihistamines like Benadryl, Claritin, and also things that are antispasmodics to help with like urinary bladder control. But what they found is that, for example, if you look at Benadryl, older adults who were using on average 4 milligrams daily for an extended period of time, they showed an increased risk of developing dementia. This wasn't excessive use of these drugs. That's important to point out. This was just regular use of these drugs over an extended period of time increased their risk of dementia. I put these little illustrations of certain drugs to help you understand the dosing. So the average dose for ZQuil, Benadryl, Tylenol PM is about 25 to 50 milligrams. And they were finding that 4 milligrams daily over an extended period increases the risk of dementia. So you have to be very cautious with these, and this is sort of a red flag that the use of these drugs, even in healthy individuals, might increase their risk of developing dementia, and you can imagine how they would affect someone who has cognitive impairment already. So, well, how can we know whether or not a certain drug might have negative effects? Well, if you're taking a drug, a prescription drug, and you're experiencing a number of side effects like greater confusion, or your loved one is taking it and experiencing things like greater confusion, problems with agitation, disorientation, you might want to look at the Beers list. And the Beers list is not a list of people's special brews, but rather it is a listing of medications that are known to cause adverse side effects in older adults. This was a list developed by a group of gerontologists and geriatric physicians about 20 years ago, and it's been updated most recently in 2012. It was based on over 2,000 studies where they looked at older adults taking these medicines and what kind of side effects that they had. So if you are experiencing or a loved one is experiencing side effects that you're concerned about, you can consult the Beers list at this website, and you might want to talk with your physician about, is there an alternative medicine that the person could use that wouldn't have these side effects? It doesn't mean you shouldn't take the drug, because drugs vary in the side effects. So some people might have side effects, others might not, and you should never stop taking a drug without your physician being aware of that. But you might want to talk with them if the medicine that is prescribed is on this listing. So if you see a behavioral change or an adverse side effect, the first thing to do is do an appropriate evaluation. So determine, is this something new? Is this a sudden change in behavior? If so, what has changed? What has changed in the medicines he's taking or she's taking? Is there something new that's been added? Your doctor might then want to do some blood tests, maybe a urinalysis, maybe even if like a brain scan, to rule out these behavioral changes aren't due to something like a stroke. So, but the key thing is to get some kind of medical intervention and follow-up.
So, you know, we've talked a lot about medical issues, but we need to remember that there might be other physical issues that are underlying a behavior. Something as simple as feeling thirsty. If the person can't express that they're thirsty, may be expressed through a behavior. If they're hot or cold, because as dementia advances, person may not realize that if they're hot, they may not realize that the resolution to that is to take off their jacket. And so they may start behaving in a different way. So this is just a list of different things to be sensitive to from a physical perspective that might be underlying a behavior. So we said that, you know, there's these 4 categories of things that could trigger a behavior. So the first one was this medical physical category. The second category has to do with cognition. This person is having a lot of cognitive changes, and so that may change the way that they behave. So this is just a list of the kinds of things that may become troublesome for the person. So whether it be that they have a limited attention span and you happen to be out together, or you happen to be at a restaurant and they're having a limited attention span, and all of a sudden they're standing up and getting up and trying to leave and walking all over the place because they can't focus and pay attention. So that's one example of how the person's cognition may affect the way that they behave. What if they have poor judgment or poor impulse control? So maybe that's a person who, because of the changes in their brain, does something that's socially inappropriate or says something that's rude. We need to be aware that cognition can affect behavior in that. Misinterpretation, one of the most common kinds of misinterpretations is when the person looks in a mirror and they can't recognize themselves anymore, and they say, oh, there's a stranger in the house, there's a robber in the house, there's a thief in the house, okay? So that's behavior is being triggered by the cognitive problem. And so we need to come up with strategies. So on the right side of this slide are just some of the ways that we can adjust. I'm not going to go through all of those because we'll never get through this talk at that rate. But, you know, let's say the misinterpretation one, which is very common. The way to resolve that is to get rid of the mirror that the person's looking into that they can't recognize. All right, so you see, you identify the behavior, which in that example was person's looking in the mirror, and every time they look in the mirror, they think there's a thief in the house. You educate, so you find the trigger. The trigger is looking in the mirror, and then you adapt. So you have to adjust the environment in that case. So your idea of how to address this behavior is to remove the mirror or cover the mirror.
We can also try to enhance cognition, and this is what we talked about in our last presentation, where we talked about the 4 FDA-approved medicines, Aricept, Exelon, Razidine, and Memantine, or Namenda. And we talked about how these are best given in the early stages, mild to moderate dementia, and how they're designed essentially to try to boost up an individual's cognitive abilities. So they're better than they would be without the drug. But these drugs do not stop the disease, they don't really even slow it down, but they sort of boost up a person's mental abilities. Well, one of the nice things about these drugs is that they've also had an added benefit in that they can help with controlling certain behavioral challenges. The cholinesterase inhibitors, that first group of 3, the Aricept, Exelon, and Razidine, they also can be beneficial for helping with mood problems. So problems like apathy, depression, anxiety, sort of restlessness, these can be benefited by the use of these cholinergic medications. Namenda has also been found to be beneficial for managing agitation and aggression. And in fact, one study showed that individuals on Namenda who had not yet demonstrated problems with agitation and aggression, the fact that they were on Namenda reduced the likelihood that they would show those behavioral problems. So these medications may be also helpful for managing behavioral symptoms. And in fact, rather than using an antipsychotic, which has all of those problems we talked about earlier, if we have a patient with Lewy body who is having very vivid hallucinations or delusions, our first choice would be to try them on, say, something like Aricept or Exelon, because that may actually be more beneficial than trying them on an antipsychotic.
There may be psychological issues that are underlying the behavior. Anything from fear and sadness, grief. One of the things we don't give people with dementia enough credit for is that they often retain some awareness of their changes. So they may not be able to understand Alzheimer's disease the way that you and I do, and couldn't explain that they had Alzheimer's disease, but they may be very aware that things are different for them. They may feel sad and frustrated. A really good example of that is an individual I worked with when I was at the daycare who I would never have expected this from, because he was quite advanced, and I had a little office and I had a picture of a brain up in my office, and that individual, that man, came into my office. He saw the picture of the brain, and he said in a very kind of garbled way, but you could make a sense of it, he said, "God's going to get that Alzheimer's guy." And again, there was a lot of other words in there, but the message got across that he was angry. And so we need to recognize that there may also be psychological, emotional reactions that are underlying the person's behavior. And depression. Depression is very common and it's very treatable, and one of the things that we can do that best treats depression is get people involved in activities that they're able to do. So a person may not be able to golf or do woodworking or cook a dinner or bake a cake, but there are a lot of wonderful things that we can engage people with dementia in that increases their sense of pleasure and their sense of purpose in life. And so there's a list of simple things that you can do with someone with dementia that you received as part of your handout. And researchers have shown that that significantly decreases depression. In the early stages, support groups are important, and we know that exercise can be very beneficial to people with dementia in terms of both wanting to try to maintain their cognition, but also relieving sense of depression.
There's also environmental or sort of the environment issues that can raise problems with behavioral problems. I think an interesting example that we had at the clinic was one of our participants brought in their father, who was a Korean War veteran, and he was, in the evening time, he was now starting to act very disturbed. He was very agitated. He was talking about people coming to get him and harm him, and so he would lock himself in a room. He was really very difficult to manage for this family, and they took him to the primary care doctor, and the primary care doctor said, well, this is occurring in the evening, late afternoon. Well, it's an example of sundowning. And, oh, he's having thoughts about people trying to harm him. Well, he's developing paranoia, and so we should put him on an antipsychotic. And so they actually, before they went to they said, well, let's think about this. And we talked about it, and we went through this idea approach. And we said, well, when does this agitation and irritability occur? Usually occurs late in the afternoon or early evening. Okay, that tells me what is the situation that causes it? Well, it's usually around when my grandchildren are there. And, oh, okay, so is this overstimulation? And what are the grandchildren doing? And the lady said, I'm not really sure, but he's usually very agitated when I come home. And so she actually observed what happened. And the grandchildren used to come in from school, and they'd put on their Xbox World War II sort of combat arms with machine guns, hand grenades, explosions, shouting, and the kids would be jumping around. And this was probably eliciting memories in this veteran, and that's why he had the paranoia and why he got all upset. It wasn't sundowning, it wasn't this sort of paranoia due to his disease, but rather the environment. Too much noise, too much overstimulation.
So the adaptation was for the kids not
to put on headphones and listen to their program, and when Granddad was in the room, put on I Love Lucy or Andy Taylor or Andy Mayberry. So don't have explosions and tanks and killing, but do something that's much more subtle. And they actually tried that, and the behaviorals went away. The behavioral problems went away. So that was a manipulation of the environment, and a lot more successful than any trying to use antipsychotics would have been.
So understand the meaning. So what is the person saying? So what is the person saying with this behavior, and also how distressing is the behavior? And we have to think about how distressing it is to the person, and also how distressing it is to the caregiver. Now, when we think about behaviors, you could have a behavior like aggressiveness, but there could be a lot of different underlying causes. So this is where managing behaviors gets really complicated, because it's not like an A, then B, then C kind of thing. You know, somebody could be depressed, and that could cause them to be irritable and be shown in some aggressiveness. They might be suspicious. The underlying issue there is fearfulness or suspiciousness, and that might cause a person to be aggressive, to try to protect themselves. There might be pain, and because of that pain, the person becomes restless, becomes upset, very uncomfortable, and could become aggressive. There could be noise, overstimulation, and the person starts to become disoriented because of all this overstimulation, and that results in aggressive behavior. So you see, you have to walk it back to see what the underlying cause is, so you could address one of these, for example. So, and then we want to adapt. And we can't expect that we're going to solve this. We're going to make the behavior change go away. But we can oftentimes ease the behavior change, make it, get it to a place where it's not so distressing to the person or so distressing to the caregiver. So we're looking for strategies, and Number one is changing your attitude. Remembering that this person is living in the world of Alzheimer's disease and that they're doing the very best that they can, given their limitations. And then there's quite a few ways to change your behavior, and we're going to have a couple more examples. In fact, we have a video coming up that'll show you some redirection strategies and other things, but let's just quickly do an example or two. So 5 years ago, Mr. K, who has moderate dementia, was injured in a car accident and hurt his shoulder. When the in-home aide gets him dressed in the morning, Mr. K screams and strikes out. So what's the behavior? Does anybody want to say it so I can actually hear you? What is the behavior? Let's be specific. Remember, we're telling it like a scene in the movie. What's the behavior? Yes, there we go, screaming. What time does it, where does it happen? In the bedroom. When does it happen? Morning, all right. Whoops, let me see if these are working. Screaming and hitting. Where? In the bedroom? When? In the morning. All right, so what might be the trigger for this? So, what we have to do is figure out the trigger. And with Mr. K, we need to have a little bit more information than we do. We do know it happens when he's getting dressed. So that is part of the trigger. But to understand the meaning, we need to know a little bit more about what he's saying. Well, he's saying, I'm in pain, because Mr. K actually has a shoulder injury, and the in-home aide doesn't know this. So if we address the pain in the shoulder, or we find a different way of dressing him, we might be able to resolve this issue. So the change is using a different kind of shirt so that it won't cause him as much pain to get dressed. And so the family caregiver's got to educate the in-home aide about this. So here's another one. Elsie, who has moderate dementia, attends daycare. We have about 10 minutes. Attends daycare. Staff report that Elsie says her husband is having an affair. She is upset and tearful throughout the day. So what's happening? Wait a minute. Paranoia is a code word. What is happening? She's upset and crying. Yeah, that's right. She's upset and crying. She says her husband is having an affair, right? We need to get rid of the code words, and we need to describe what's going on to understand what to do. So she's upset and tearful. Where is this happening? Daycare, right. When is this happening? All day? Throughout the day. That's right. All right. What's the trigger? Anybody got an idea what the trigger might be? This is another one. That takes what? Daycare, right. Somebody's heard me tell this story before, I bet. No? Because I have told this story before here. Going to daycare. It actually is going to daycare. Elsie's a real person I worked with in the 1990s. I talked to her husband to work this out, because I couldn't figure out what the trigger was, why she was always so upset and saying her husband was having an affair. So I sat down with him and said, you know, Elsie keeps saying you're having an affair. What's going on? And he said, she never says that at home. So we figured out the trigger was daycare. What do you think Elsie might have been saying? I want him to be here. Yeah, that's getting pretty close. I think she was saying something about affection. I want some affection. I miss my husband. She wasn't about to say, oh, I'm going to daycare because I have memory problems, right? She's going to daycare. Her husband must be going out on her. So in actuality, she was saying, I need more affection, because what we tried in that situation was, now he would hold her hand when he brought her to the daycare, give her a kiss, and say goodbye. When he came back, he made a point of being very happy to pick her up, to see her, give her a kiss, say hello, she became one of our happiest daycare participants. Her saying, he's having an affair, wasn't being paranoid. It was really saying, I'm feeling abandoned and I need more affection. Okay, that's why we have to get rid of the code words. And so one of the best ways to redirect individuals is to shift their focus by giving them a compliment. You know, giving a compliment makes us all feel good. And it's something so simple as noticing somebody's blue eyes, or also in this example, asking them to help. But there's a short video here. Part of the reason I'm pushing through this is I
got a 911 page to come up to the floor. And what had happened was this woman started to become a little bit agitated. So she started looking around her room and no longer recognizing anything in the room. And so she was going from room to room looking in the rooms. And so when I got to the unit, she was kicking the door of the room to get in and was screaming. And so as I was walking down the hall, I was thinking, oh my goodness, what am I going to do? And I went up to her and I said, Mary, how are you? And she stopped kicking and just turned to look at me. And I said, I'm making some tea. How about having a cup of tea with me? And I could see in her brain and in her eyes that it just completely broke that thought process of trying to find her bedroom. And she said, well, okay, that sounds good. And that's how we got her back in the room. So if you understand what's going on and try some tactics that you kind of learn, getting someone's attention away from what they're trying to do and focused on something you want them to do is often really helpful. Even with dementia, people need to have a purpose. So I sat with this woman, we had tea, and what I said to her was, I need some new pictures for my office. How about if we sit? I've got some paints, and so she was perfectly happy to sit and paint. We always need to keep in mind who these people are and the fact that they do need to accomplish something.
So that's really a wonderful video. And, you know, she said, you know, would you like to have a cup of tea? And so she said, you know, would you like to have a cup of tea? And the important thing there is she followed through and she had the cup of tea. She just didn't say, would you like to have a cup of tea, to distract her. And then she got her engaged in an activity that's meaningful. There's another short video. So one of the things that happens so often is that people with dementia start looking for someone who's passed away, looking for a mother, a sibling perhaps who's passed away, and this becomes often very difficult. And one of the best ways to address this behavior, because so many caregivers ask, well, should I tell her her mother's dead? Should I pretend that she's alive? What we need to do is look at the underlying message. If someone with dementia is saying, I'm looking for my mom, I want to go see my mom, what they're usually saying is that they missed the person. So a strategy to learn is how to validate the feelings of someone with dementia. Don't focus so much on the actual words of what the person is saying, but focus on the feeling that's behind it. So in this case, you look worried. So she's looking worried. She's talking about her mom who died. It seems like you're missing your mother. And what's really important then is to try to engage them in a conversation that allows them to reminisce about their mother, to feel close to their mother. And so in this case example, oh, you grew up on a farm, Kansas, your mom must have been hardworking. And that underlying need to be close to mom, to feel safe, to feel connected. You know, one way to say that is mothers are special people that keep us safe. You're safe here too, you're safe. So go for the underlying feeling. You know, I talk about the truth in the feeling. It's not about whether the words are true or arguing about whether mom's dead or alive. There's one more video here that we'll show before I think we need to end here quickly. So,
Mrs. Leon, what's wrong?
I'm going home. I have to go home. My daughter is waiting.
Oh, you mean your daughter Kim? How old is she now?
She's just one, a baby. That's why she needs me.
Oh, that's okay. Kim is safe. I'm sure of that. There's no need to worry.
How do you know? Have you seen her?
Yeah, I saw her last week. How about if we phone your daughter Kim and find out how she's doing?
You mean call her now?
Yeah, but let's call her from your room. It'll be quieter in there.
Okay.
Oh, and you have that lovely family photo album. We can look through that. Oh. And in this picture, which one's Kim?
Here. She's in the middle.
Yes, she's beautiful.
so just a little short video about that and about how to help the person focus in a positive way. So what we're not going to do, because it's just gotten way too late, I always bring too much information. You have a number of slides that, rather than trying to rush through them, provide you some strategies for how to communicate effectively with a person who has Alzheimer's disease from the early stages to the most advanced stages when the person is close to death. So how might you adjust the way that you talk to the person, whether that's, speaking slowly, taking it step by step and so forth.